Good afternoon. I'm Robyn Grant, Director of Public Policy and Advocacy for the National Consumer Voice for Quality Long-Term Care, and I want to welcome you all to today's webinar entitled A Deeper Dive into the Revised Federal Nursing Home Regulations, Part 2. So this is the next in our Deeper Dive series designed to give you a more in-depth understanding of the revised federal nursing home regulations. Next slide, please. So this webinar is going to focus on three major topics. First, admission, return to the facility, and bedhold, which will be presented by Eric Carlson, Directing Attorney with Justice in Aging. Next, you'll hear from Lori Smetanka, who is the Executive Director of Consumer Voice. And Lori's going to talk about visitation rights. And then the third topic is specialized rehabilitative services, which Toby Edelman, Senior Policy Attorney with the Center for Medicare Advocacy, will talk about. So just to note, all three of these sections of the revised rule are already in effect as part of Phase 1. So after you hear from our three presenters, you'll then have the opportunity to ask some questions. Next slide, please. Before we start, let me just cover a few logistical details. Right now, all of your lines are muted, so everyone can hear the presentation without background noise. As I said, we'll answer questions at the end, but if, as we're going through, you have a question prior to the Q&A part, you can ask it whenever you like, and all you have to do is type it into the question box that's located on the control panel on the right-hand side of your screen. Also, as you may have heard just a moment ago, the webinar is being recorded, and we'll make both the webinar recording and the PowerPoint slides available following the webinar. So not to worry, we know that most people really want to have copies of those slides. So know that they will be made available. So with that, because we have a lot to cover, let's go ahead and get started, and I'm going to turn the webinar over to Eric.
Terrific, thanks Robyn. Next slide, please. First, talk about some issues that come up at the time of admission. The regulations require that that resident rights cannot be waived. That includes explicitly rights under the federal regulation and rights that a resident may have under licensing and certification laws. And it applies whether the waiver has been required or requested. This language comes up multiple times in these provisions, and the reason for that is that in past years, a lot of nursing facility admission agreements have had residents supposedly volunteer to do certain things, to waive certain rights, have people volunteer to become financially responsible, and that was to set up defenses to regulations. The laws at those times prevented nursing facilities from requiring certain things, and then so the nursing facilities in their defense would have people sign agreements that talked about volunteering and then say, well, we haven't violated the law. We haven't required anything. These people are volunteering to waive rights or take financial responsibility, whatever it is. So this is an improvement in the language by adding the word request that presumably torpedoes these arguments used in the past that people have volunteered to waive rights or take on responsibility. Next slide, please. Another inappropriate waiver would be the right to Medicare or Medicaid benefits. Practically, this is most meaningful in terms of Medicaid benefits because nursing facilities are happy to get Medicare. That's that's one of their favorite, maybe their favorite reimbursement source. But there have been over the years problems with Medicaid reimbursement, and in some of the worst case scenarios, facilities have had residents make what are oftentimes termed duration of stay agreements that go along these lines. Sure, we're happy to admit you, but you need to commit to us that you will pay privately at least 3 months or 6 months or a year or 2 years, whatever it is, before you go off and apply for Medicaid eligibility. Those provisions are inappropriate under Medicaid law, and this makes that explicit in this context, that a resident is prohibited from waiving his or her right to receive coverage under Medicare or Medicaid. Next slide, please. Also, this deals with residents' property, that the regulations now explicitly prohibit a waiver of the facility's obligation to look after the resident's property or the responsibility for property that might end up being lost or stolen. I should note here that that does not mean that the facility is automatically liable whenever something is lost or stolen. It just means that the facility cannot preemptively come up with an agreement whereby the resident supposedly absolves the facility from any responsibility from something that may be lost or stolen. The language here on that substantive issue, who's responsible, is a little bit better than it used to be. You'll see the cited language here that the facility must, quote, exercise reasonable care for the protection of the resident's property from loss or theft. Well, then the question from that is what's reasonable, and people are likely going to argue about that. From the resident's point of view, the resident wants to argue with reason that the facility bears significant responsibility here, particularly if you're dealing, as you oftentimes are, with residents with dementia or some other cognitive limitation, and they're in a nursing facility because they need a lot of assistance, and they find it difficult to do some of these things and keep track of things, that it makes sense that a facility, for example, might have some responsible. It would be reasonable for the facility to have some responsibility for jackets, sweaters, dentures, whatever the thing may be. Next slide, please. Another issue in admission is financial liability. And for years, there has been a provision in the federal law that prohibits financial guarantees. That now by third parties. So the resident, of course, is perfectly appropriate for him or her to be obligated to pay for the nursing facility bill, of course. But it has been not allowed for the facility to get the financial obligation of a third party like a family member or a friend. It's too much of a burden. If there's any problem with payment, if the resident runs out of money, Medicaid should be there, and it's potentially a crushing financial obligation of undetermined amount if someone were to co-sign on a nursing facility admission agreement. What are they potentially liable for? $500, $1,000, $5,000, $15,000? You just don't know. And for all those reasons, the federal law has prohibited that. A lot of nursing facilities have chafed at this restriction and have looked for ways to avoid it. This is one of the areas where in the past facilities have sometimes claimed that they haven't required a family member or friend to take on financial responsibility, that those persons have volunteered to do so. That's ludicrous, because who in their right mind would jump up and volunteer to become financially responsible for something when that's not required? And there have been arguments in the past why that's inappropriate. Those arguments are bolstered now by the improved regulatory language, which doesn't just prohibit a facility from requiring these third-party financial guarantees, but also prohibits them from requesting them as well. I'll notice that there's still some open issues here. These days, a lot of the activity in the collection side of this is based on admission agreements that don't formally require a co-signer, but have, as is appropriate, have a family member agree to pay the resident's money for nursing facility charges. Again, it makes sense. If, for example, a resident is incapacitated and unable to make the payments by himself or herself, it's appropriate to have an agent sign on the resident's behalf obligating the resident's money to be paid towards the nursing facility bill. Facilities have used language which has that third party, friend, family, whomever, agree to pay the resident's money and also to take all necessary steps to arrange for Medicaid eligibility, and in some cases then has filed suit against the family member or friend, the so-called responsible party, when the bill isn't paid. Those provisions and those arguments are really questionable because it's a backdoor way to essentially make a third party financially liable, and it violates the general rule that agents aren't liable for the debts of the principals. If I'm representing a business, let's say, and make an arrangement for that business, I'm not liable for that business's debts. I'm just acting as an agent. The same thing should be true in this case. But just so people are aware of this, courts have come down on both sides of this issue, sometimes finding the third party liable and sometimes not. Generally, when the third party has been found liable, the facts are really egregious. You've got a family member who's essentially booted the resident's account and it hasn't paid the facility. And because the facts in those situations are so unappealing, sometimes the judges involved have made some legal determinations that maybe are questionable, let's say. So CMS was made aware of this in the regulatory process, and CMS said in the comments surrounding the regulations that more study was needed, and that maybe they'd have something to say about this question subsequently in guidance. So that's where it is right now. The law is better. The voluntary, so-called voluntary financial guarantee should be right out. There's still some ambiguity around these common facility provisions that are based on the family, sometimes lead to lawsuits based on the agent's agreement in the nursing facility admission agreement to pay the residents money and to take all necessary steps to get Medicaid eligibility set up. So with that, let's move on to the next slide and talk about arbitration, which has maybe gotten the most press attention of anything in these new regulations. The federal regulations bar pre-dispute arbitration agreements. And the comments from CMS surrounding the release of the regulations explains why, that arbitration generally isn't a good choice for consumers. They tend to fare better in court than in private arbitration for a variety of reasons. And this is, I think, the best argument against arbitration in this setting. There's no reason and it responds to the facilities argument saying arbitration might be quicker. We can argue about this, but it might be quicker. It might be less expensive. It gets a resolution more quickly, et cetera, et cetera. But the relevant point there is if that's true, residents and their attorneys in this case, after an injury has been suffered, for example, should be able to make that decision themselves. If it really is a better option, they could choose that option and decide to go into private arbitration as an alternative to court litigation. But that's not how these things are set up. They're presented to people in an admission agreement at the time of admission to a nursing facility when residents have and their family members have 1,000 other things to worry about, when they feel obligated to sign whatever is put in front of them. So it's a completely one-sided process as far as decision making is concerned, and that's not the time when decisions should be made on this, and that's why this is called pre-dispute. It's before the dispute has even arisen, when no one understands what's potentially at stake. So CMS released a regulation that bans pre-dispute arbitration, There was then a lawsuit brought by provider groups in federal court in Mississippi, and the court has blocked the implementation of this ban against pre-dispute arbitration. So right now it's as if the ban doesn't exist. The judge agreed with the policy behind the ban, but found that CMS had exceeded its authority, and also found that the arbitration provision violated the Federal Arbitration Act. The case is on appeal, but there's certainly some question there as to how that's going to play out. The appeal was taken by CMS in late December, early January, before the new administration, the Trump administration, came in. So it's certainly possible, maybe likely, that the Trump administration will take a different position, although they haven't said anything formally at this point. One other mention about admission agreement, there's also a helpful provision in the residents' rights that says the terms of admission contract cannot violate any provision of the regulation. So sometimes you see admission agreements that misrepresent, for example, the transfer discharge rules. And in the past, when people have sometimes complained to the surveyor about that, the response is, well, that's an admission agreement. We don't have anything to do with that. We deal with health and safety now with admission agreements. But now there's this explicit provision that says that the admission term contracts can violate the regulation. So if you see that, it's now something that should be addressable by the surveyors. So moving on from admission to the next slide, and then I think maybe even go then to the slide after that, we're going to talk about bedholds and returning to the facility. A facility, as was true under previous law, has to give notice of state bedhold rules and the facility policy. That has to be given at 2 times before the transfer, which is usually at the time of admission in the admission agreement, and then at the time of the transfer itself. There's a second provision, go on to the next slide please, that gives a resident a right to return to the facility. It applies when the bedhold period has been exceeded. So even if the resident's been in the hospital, let's say for a month, 2 months, doesn't matter, he or she has the right to come back to the previous room if it's available, or to the next available semi-private room. So Medicaid's not going to pay for an empty room for a month or 2 or 3 months, but the resident has a right to come back to that facility if the resident is eligible for reimbursement under Medicare, which shouldn't be a problem given the high Medicare reimbursement rate, but also under Medicaid, which is a context in which this occurs more frequently. The next slide, please. What happens when a facility says, no, we're not taking you back? It's a common problem. The facilities, in some cases, take advantage of the resident's hospitalization to refuse admission and to essentially rid themselves of a resident whom they consider undesirable for whatever reason. There's some better language here from CMS. First, the regulatory language that we're looking at here. The facility in those situations must comply with the transfer discharge procedures as they apply to discharges. So I think from an advocacy perspective, what we want to argue is that the fact that the person is hospitalized doesn't change the facility's obligation. If they want to discharge, they still have to give notice and go through the process. And while that's pending, they should be readmitting the person, because as the transfer discharge rules make clear, you can't take any action on a transfer discharge until the process has run the course, and if appeal has been taken after the hearing has been held. And going on to the next slide, there's a CMS discussion in here surrounding the regulation that recognizes this incidence of resident dumping in hospitals, and notes that the changes in the regulation that they've taken have been meant to limit the ability of facilities to quote-unquote dump residents in hospitals. So with that, we can move on to the next slide and the next topic, the visitation rights.
Great, thanks Eric. Next slide please. So in this section of the revised regulation, CMS has affirmed a resident's right to designate visitors and decide when they want to receive them. Most of the language in this section has been maintained from the previous version of the regulations, but there have been a few changes, which we'll talk about. But the primary point here is that control over who is permitted for a visit and when they come in for a visit and who comes in and when they come in lies with the resident. The resident has control over who they want to see and when they want to see them. So as long as a visit is not imposing on the rights of another resident, the facility cannot place limits on who the resident receives as a visitor or when the visit occurs. So in other words, that means no visiting hours are permitted for nursing homes. There are limited exceptions to these rights, and we'll cover those in just a few minutes. Next slide, please. The sections of the regulations organize the visits by types of visitor. So for this first group that you see on the slide ahead of you, it's made up primarily of individuals or entities that are responsible for the health and welfare of residents or those who provide advocacy or support. And there is an immediate and unrestricted access to the resident by these individuals at all times. So in this section, it's mostly the same as in the previous regulation, and it does require the facility to provide immediate access to the resident for representatives of the Secretary, which means the Secretary of the Department of Health and Human Services, or of the state. And examples of those folks would be state and federal surveyors. So those that come in, the facility has to provide immediate access to the resident for surveyors. Also for representatives of the Office of the State Long-Term Care Ombudsman, which would include not only ombudsman staff, but also volunteers, anyone who's a designated representative of the program. It includes the resident's individual physician, representatives from the state's protective and advocacy systems, also known as disability rights networks in some states. And newly added to this section is immediate access to the resident's representative, which CMS has defined as an individual chosen by the resident to act on their behalf, a person authorized by state or federal law to act on behalf of the resident, or a legal representative such as a guardian or a person indicated by power of attorney. So someone that the resident designates themselves is guaranteed immediate access to the residents in these situations. Next slide. For immediate family and other relatives, again, the facility has the responsibility to provide immediate access to the resident, subject to the resident's consent. And that consent from the resident may be denied or withdrawn at any time. So again, the resident has control over who they want to see and when they want to see them. According to CMS, this regulatory language is intended to convey that the visitation should occur when it's most convenient for the resident and the person with whom they want to visit, not the convenience of the facility. So we hear a lot of times from folks that a son may want to come and visit with his mother after getting off work at 11 o'clock. Well, that's okay. If the mother agrees to the visit and their visit's not disturbing other residents, then it's okay for them to have their visit at that time. They can't be banned by visiting hours. If the visit would be disturbing to the mother's roommate, for example, the answer isn't to ban the visit, but rather to find another place in the facility where they can visit in private. So accommodation should be made so that the resident can visit with the person of their choice whenever it is that they want. One of the provisions that was added to these revised regulations related to language around spouse or domestic partner is that it specifically includes same-sex spouses and same-sex domestic partners in those references. So that's a new addition to these regulations as well. Next slide, please. For other visitors, non-family members or relatives, so friends, for example, or other people that the resident chooses to visit with, again, the facility must provide immediate access to the resident as long as the resident, again, consents to the visit. That's a common theme that you'll be hearing throughout all of this section on the regulation. So for this group of people, of other visitors, the regulations have allowed for reasonable restrictions, which CMS revised to clarify that any restrictions must be based on clinical or safety restrictions, not just reasonable. They have to specifically be related to clinical and safety restrictions. So according to CMS, where they talk about the section in the comments of the preamble, a clinical restriction could refer to limiting other visitors to prevent the spread of communicable diseases, for example. A safety restriction might include denying access or providing limited and supervised access to a visitor who's been found committing criminal acts, or denying access to visitors who are inebriated or disruptive. CMS notes in the preamble that some safety restrictions may be imposed by a facility to protect the security of all residents, such as locking the facility at night. But if these practices are put into place, the facility must also put into place systems for allowing approved visitors to enter when the visitation is requested by or required by the resident. So that could include providing them, for example, if the facility locks the doors at night and a visit's to occur, in our scenario a minute ago, the son who wants to come in at 11 o'clock after he gets off work, the doors are locked, the facility needs to provide or have a system for providing him access into the facility, such as a code for entry or giving them other instructions for entering the building. But they can't just blanketly deny them access to the facility. Next slide. The last category of visitors listed in the regulations include those that provide health, social, legal, and other services to residents. And for these visitors, the facility is required to provide reasonable access to the resident, and again, only with the resident's consent. As before, the resident can withdraw or refuse consent at any time. Again, according to CMS, the only reasons for denying reasonable access would be for clinical or safety reasons, similar to what's required under the reasonable restrictions that could only be for clinical or safety reasons. So if they're not clinical or safety concerns, then the facility needs to allow access to the residents by these visitors, again with the resident's consent. Next slide. The revised regulations include specific requirements that facilities must comply with regarding visitation. So first, as we've mentioned, the facility must provide visitors immediate access to the resident with the resident's consent, or as mentioned on the last slide, reasonable access to the resident in the case of the last type of visitors. So again, that means if a family member or friend comes to visit and the resident wishes to see him or her, the facility cannot deny them entry no matter what time of day or night it is. As long as the resident consents and other residents are not being disrupted, the visitor must be permitted to see the resident. The facility must also develop policies and procedures regarding visitation rights. These policies and procedures must be written and must include what constitutes reasonable health or safety restrictions and the rationale for those restrictions. The facility has to specify the reasons that would cause it to impose the restrictions and to whom they might apply. So according to CMS, limiting the restrictions to health and safety concerns and requiring the rationale for including them in policies and procedures should be useful in identifying and preventing inappropriate restrictions on visitations, which we know has been a significant problem with residents and family members in receiving some visitors. Next slide, please. Also required is for the facility to ensure that visits are not limited, restricted, or denied based on race, color, national origin, relation to the resident, sex, gender identity, sexual orientation, or disability. There needs to be assurances that all visitors that the resident wishes to see has an opportunity and access to them. And then lastly, the facility must ensure that all visitors have full and equal visitation privileges consistent with the preferences of the residents. Throughout the regulation, we see that the control for the visits lies with the resident, not with anyone else. Next slide, please. So as we've been looking at these provisions and the regulations around visitation, some of us have been thinking about different scenarios similar to the ones that you see up on the screen right now that we've heard examples of from consumers or ombudsmen about some different restrictions that have been placed on visitors. And we know that some visitors and some visits can be challenging for facility staff, for other residents, and the regulations don't always have the answers. The intent of the regulation is to put control of the visit with the resident and to assure that they get to see and visit with whomever it is that they want. So what we know from reviewing them is that the regulations are very resident-centered and provide that absolute right to a resident to visit with certain people, particularly family members. And as you recall, the reasonable restrictions for clinical and safety issues are very limited in how they may be applied. So certainly it's important that we preserve the resident-centeredness of the language, but we also need to recognize that at times it's going to butt up against a facility's obligation to all residents. So in thinking about some of these different scenarios, certainly we know that each situation needs to be evaluated based on its own set of facts and circumstances, and that a facility needs to assess what options are available for addressing challenging situations and what actions might be required. So for example, in the third scenario that we've listed up there, where a daughter is repeatedly trying to help her father out of bed without the appropriate supports, we really have to question, is the right response to try to restrict her ability to visit? Could the facility ask her, for example, and her father to attend a care planning meeting with staff to discuss the concerns of both staff, the daughter, and the resident, and then establish a plan for moving forward rather than just trying to ban her from the facility or to restrict her visits? There need to be other options that need to be considered. And the facility needs to determine what other responsibilities that it has as well as other options. So as we think about different scenarios, is there abuse that needs to be reported, for example, or can social services or a counselor work with the resident to assess how they might feel about the challenging visits of family members and to come up with a plan for responding to them? Can a private room be set aside for certain visits? Plans can be developed with residents to try and address certain types of situations. So before we look at just requests to ban visits, facilities need to be challenged back to look at what other options are available. And so certainly we do welcome your thoughts and examples of how facilities can respond to these visits that would still respect excuse me, the resident's right to spend time with the person of their choice. And we hope to be having ongoing conversation about this in the coming months. So with that, we'll stop on this section and I'll turn it over to Toby.
Thank you, Lori. Next slide, please. This section is about specialized rehabilitative services. Generally, the regulations governing these services are unchanged from the prior regulations. Facilities must provide physical therapy, speech-language pathology, occupational therapy, and rehabilitative services for a mental disorder or intellectual disability to any resident who needs one or more of these services. What's new in the regulations, the major exception, is the new requirement, the explicit requirement that facilities provide respiratory services to residents who need them for their breathing problems. Respiratory services include a wide variety of devices such as CPAP devices, nebulizers, oxygen concentrators, and more. But the big question is whether facilities must provide ventilator services for residents. And on that issue, the regulations and preamble are not particularly helpful. CMS declines to define the scope of respiratory services that all facilities must provide. Instead, it says facilities must use the facility assessment process to decide what resources and staff they need in order to provide care to their residents. As we've discussed before, the facility assessment is an annual procedure done at least annually and as necessary for the facility to determine what resources and staff it needs to take care of the residents. What CMS also says in the preamble is that once the facility has conducted its assessment, it doesn't have to change it unless it begins admitting residents that need substantially different care. So is respiratory care, is ventilator care substantially different care? We don't really know. CMS's answer about whether facilities have to provide these services or what type of respiratory services to say it's up to the facility and its assessment process is an unsatisfactory answer. I think the regulations are clear that if an existing resident develops the need for respiratory services such as a ventilator, then the facility must provide that service. Whatever existing residents need, the facility must provide. But the regulations are not as clear about whether the facility is required to provide ventilator care if it's never provided that care in the past, if it's never had residents who need that service in the past. I think this is an issue that advocacy will have to be done at the facility level before somebody comes to the facility looking for ventilator care. Be a little bit difficult at that point. Next slide, please. The regulations, next slide after that, please. About outside providers. Yes, thank you. If a facility does not employ the specific therapists whose services are needed by its residents, then the facility may use an outside provider. But these providers are not required by the regulations to be certified for Medicare or Medicaid. Instead, CMS says only that these outside providers may not have been excluded from Medicare or Medicaid. And that's a much more limited requirement. If a facility chooses a non-certified outside provider, then residents are going to have to pay much more money for those services, and that may start becoming a barrier. Next slide, please. Another new requirement in the physician services rule that's relevant here is the provision that allows a physician to delegate to the therapist the responsibility to write the therapy order. The only limitations on that delegation are that the therapist must work under the supervision of the physician, and the delegation must be consistent with the state scope of practice laws. Is it within the therapist's scope of practice to be able to write a therapy order? This gives us a new opportunity to advocate with some additional people to get therapy services for clients, not just the physicians who may not really know anything about it, but possibly the therapists as well if they've been delegated in a particular case. Next slide, please. Some commentators had suggested that the regulations should acknowledge the JIMO decision, and CMS says in the preamble that the settlement in JIMO doesn't fall within the scope of the regulations. But from our perspective, JIMO is relevant for advocates for residents who need therapy services. We've often heard in the past that facilities say to the family, your mother has plateaued, she's not getting any better, and she's being discharged from Medicare. There are two problems with this common statement that we hear. The first is that the JIMO settlement, a federal court case in Vermont, this settlement confirms that Medicare covers therapy services and also nursing services if the resident needs professional therapy services to maintain function or to prevent or slow a resident's decline or deterioration. In other words, Medicare is not limited to residents who are improving or who are expected to improve. If somebody needs therapy to maintain function and to function at the highest possible level for that individual, and this needs to be an individualized determination, then Medicare will cover it, either through Part A, if the resident is in a Part A stay, or through Part B, if the resident is not in a Part A stay, and say private pay resident, but still needs therapy services. So the statement that facilities typically make, your mother has plateaued, Medicare is stopping, that is not correct. It's an incorrect understanding of the Medicare law and the Medicare coverage rules. Second, what residents and families often hear when the facility says your mother is discharged from Medicare, they hear that this means the mother is being discharged from the facility. And that is also incorrect. Even if Medicare does not pay for a stay in a nursing facility under Part A, the resident can still stay in the nursing home as long as the resident has a source of payment for that stay. So the typical two alternative sources of payment for a stay in a nursing home are either Medicaid or out-of-pocket private pay payments. So denial of Medicare coverage has one set of appeal rights, and discharge from a facility under the Nursing Home Reform Law has another set. And we have a link in the issue brief that accompanies today's webinar that cites two materials that the Center for Medicare Advocacy has written about these two separate and distinct appeal systems. But the point is that more residents probably are entitled to therapy services, to maintenance services, maintenance level of services under the JMO case. And even if Medicare stops paying, that doesn't mean the person needs to leave the nursing facility. So I think, Robyn, back to you for the next part of our webinar. Thank you.
Thank you so much, Toby, and thank you to Eric and Lori also for all the very valuable information that you all provided. We now want to give all of you a chance to ask some questions. So you can submit questions in your question box that's located on the control panel on the right-hand side of your screen. And we're going to give you just a moment to enter your questions, and while we do that, I want to first of all introduce Alicia Lineswalla, who's our public policy and program specialist, who's been the person behind the scenes assisting with the webinar and who's helping us with asking your questions. I also just wanted to say that last time on our Deeper Dive webinar, we mentioned that the revised nursing home regulations were possibly subject to repeal under a law called the Congressional Review Act. So we just wanted to let you know that at least to date, there has been no action taken to repeal the regulations. So that's all we know, but we did want to kind of give you that update. So now, Alicia, are we ready for our first question?
Sure. Thank you, Robyn. So we've had a number of questions about resident dumping, so I'll ask one of them. In terms of dumping of residents at hospital, we have facilities who claim danger to other residents or staff every time, so they aren't obligated to take the resident back. Do the rule changes make any difference for this situation?
This is Eric. I think they do. They make it better for the resident because there's this explicit reference to the transfer discharge rules. When facilities refuse to take somebody back, they're always making claims about we can't either meet your needs or this person is a danger to safety or health. My experience has been with those that those are generally, or almost always, or always spurious, that these people they're not really dangerous, and a lot of times the danger and injury that comes out of these are, you've got an 80-something-year-old client and he pushed a staff member, this sort of stuff. But let's assume that if it really is a legitimate danger, however you want to envision that, there are provisions in the nursing home reform law that allow for less than 30 days notice, that just whatever practical notice there is. And so if a facility really believes that this person is absolutely a danger, they could dial down the notice to low level and make their claim and take extreme efforts in that regard. But again, so that's the response to facilities to say, oh, this is the end of the world, we're going to have to admit all these crazy, dangerous people. I don't think that's the case. It's never been the case in my experience. If that 1 out of 1,000 incident were occurring, the appeal process would just have to be done as quickly as possible, and facilities would have to take the necessary steps in the interim. But the bottom line is you still have a right to an appeal hearing before you're forced out.
Thanks,
This
Eric.
is Toby. Could I just say something about that too, Alicia? Is that all right?
Yeah, go ahead.
From reading administrative law decisions where facilities appeal deficiencies and this type of issue comes up, I think the administrative law judges say that the facilities have options. If they think somebody is dangerous, then they will say sometimes we need to have one-on-one supervision, and they do that briefly. But if that's what they need to do, then that's what they have to do. They can't just argue that I totally agree with Eric that it's an excuse and not justifiable and should be challenged.
Thank you both for answering that question. We also had a number of questions regarding visitor visitation in terms of the resident representative or the guardian or the power of attorney. So I'll ask one of those questions too. Regarding visitation, does the guardian still have authority, if granted by the court, to withhold a visit if the resident wishes the visitor to continue to visit?
So I am seeing a lot of questions about powers of attorney and other resident representatives being asked, and understand that that is a huge issue. So first of all, the regulations, as you've noticed when we went through them, left the authority for deciding who gets to visit with the resident. At no point in those regulations does it say that a resident's representative has the ability to make those decisions for him or her. And certainly when you're looking at particularly a power of attorney, you need to look at what that authority is. What does that power of attorney, what rights and responsibilities has the resident given to that person under power of attorney, whether it's to make health decisions for them or financial decisions that doesn't involve visitation rights. The other point is that if a resident has the ability to express their wishes to see someone, then that should be respected to every extent possible. And so certainly if a resident is wanting to see an individual, then they should be permitted to do that. And that's listed under good guardianship practice as well. When you look at good guardianship standards, that they should be taking into account the wishes of the resident at each point, and should try to honor those wishes whenever possible. So for each of these situations, whenever possible, if the resident wants to see an individual and can express those wishes, or through past behavior has shown that they want to visit with that person, then they should be able to do so whenever possible.
Great, thank you, Lori. Another question is by an advocate who is continually told by therapy staff that the resident has met goals and no longer needs therapy. However, the resident insists that he or she still needs therapy in order to maintain current level of function. How can the resident or advocate support the GMO outcome?
That's a really important question and a very difficult question, and I'm not sure I have the answer to it. We're struggling with that all the time. You know, I think one unfortunate answer might be if the therapy actually is stopped and the family is unable to persuade the nursing home or the therapist or the physician who's ordering therapy, unable to persuade them that the therapy should continue uninterrupted, and if it is interrupted, I think the family or advocate could be saying, we need a new evaluation in a week. And if there's any sign of decline or deterioration, to say, start therapy again. And if somebody is in a Medicare Part A benefit period, and the benefit period, suppose the person has gotten 30 days of therapy and there's a maximum of 100 days, if there's a break of no more than 30 days, that benefit period could resume. So it's not a great solution to have the therapy end, but that's one possibility. The other thing to try to prevent the therapy from ending is possibly to get like the resident's primary care physician from the community to weigh in with the physician or the therapist and explain why that therapy is necessary and why it would be helpful. We have some examples of letters where the therapist or the physician in the community wrote a letter saying why this particular resident needed additional therapy, why it was appropriate, what the goals were, and how the person would benefit and had benefited in the past from therapy. Letters like this sometimes persuade people, and I'd be happy to send people the letters we have and a template that an attorney in either New York or New Jersey developed based on these letters that we had redacted. So it's like a fill in the blank to try to get the community physician to persuade the nursing home physician, or now, in addition, the therapist to continue the therapy. But if all else fails, try to get it resumed if it is discontinued and the resident declines to some extent.
Thanks, Toby. So going back to return, there's a question on the right to return to the facility. Does it only apply when a resident has gone to the hospital? What if the resident went home and failed?
The regulation refers to hospitalization or therapeutic leave. So I would say that that does not apply, as I understand the question, to a situation where a person leaves to go to home and it ultimately doesn't work out. And my guess on therapeutic leave is just an approved leave. Maybe some others on this call have a better idea. I would think of that as being a visit to a friend or family member for X number of days when it's considered just appropriate for the person. It's not that they're leaving indefinitely, they're just leaving to visit somebody else. I think that's what a therapeutic leave is. So I'm thinking we're talking here about a hospitalization or a visit like that to others, but not to the situation put forward by the question when you really are trying to move out and go home, but it ends up not working for you.
Great, thank you, Eric. So another visitation question, probably one that has a lot of practical implications. What if a resident wishes to have a visitor stay the night? Is that possible?
So certainly a resident doesn't have the right to have a visitor live in the facility with them, 24 hours a day on an ongoing basis, day after day. But if there were an instance where the resident would like someone to spend the night with them, certainly they should have the right to do so and work with the facility to determine what accommodations would be made. So if it's sitting by the resident's bed during the night, then there's no reason why that can't happen. So certainly talking with the facility staff about it would be preferable in terms of just letting them know what the status of the situation is, but they should have the right to have someone stay with them if they'd like.
Great, thank you. And another visitation question. In addressing resident visitation, how does a doctor's statement or psychiatrist's statement that certain visitors not be allowed due to their negative impact on the resident's mental stability and status practically play out?
Well, so I think this is one of those situations where the regulations really don't address something like this. And again, the regulations leave the control over who they get to visit with the resident. It doesn't provide an opportunity for a physician or a family member or anyone else to deny access to the resident if the resident wishes to see that person. So this is one of those situations where there needs to be communication and another plan put into place for how to honor the wishes of the resident to see that individual if possible, while also respecting the safety and the concerns that might have been raised by others. But this is not one of those easy cases, and certainly it's one where there needs to be good planning and communication between the resident and the physician and the facility staff.
Great, thanks, Lori. One last question relating to bedholds. When a bedhold runs out, facilities are stating by not paying for the bedhold, a resident is discharging themselves. What is the appropriate response to this practice?
Thinking here for a second, which doesn't quite work on a webinar, that I think you still have the right to return is what I think what you'd focus on. That the right to return doesn't depend upon holding the bed. and so because of that, there's a right to return, even though the actual bed is not held. But it is a little tricky because the right to return is dependent upon the bed hold period being exceeded. Let's assume that the facility if the facility doesn't give adequate notice of the bed hold, either of those two ways, either prior to the transfer at the time of admission, then the person didn't get adequate notice of it. It would argue that because they didn't have adequate notice, they didn't have any obligation to exercise that bed hold. But let's assume that the facility did give clear notice, and the resident didn't exercise that, and then I do think that's potentially a problem if the facility would want to really push it. Residents want to be clear about this when they get the bed hold notice. They want to go back. They certainly want to be clear that they intend to return. If the person's eligible for Medicaid, Medicaid's going to pay for that designated bed hold period set up by the state. If they're not eligible for Medicaid and it's being paid would have to be paid on a private pay basis, then they'd have to be prepared to do that. Otherwise, I do think there's some risk that the facility would say, we gave you the opportunity to hold the bed, you didn't do it, and so you don't have the right to come back.
Thanks, Eric. So one last question on therapy. As an advocate, how can we compel a facility to provide more than restorative therapy to a resident whose payment source is Medicaid? Especially with TBI, improvement can be slow, but still happen with more intensive occupational therapy and physical therapy as well as speech therapies.
Such a good, difficult question. That's one of the concerns I think many of us have, that therapy is really only provided to people who are in a Medicare benefit period or getting Medicare to pay for it. And many residents who are on Medicaid, or maybe most residents on Medicaid, don't get any therapy at all. That's why when we look at nursing home compared and we see what's the average number of minutes of therapy in a facility, it's trivial, like 5 minutes a day for most people. So it's the Medicare people who are getting therapy and not Medicaid. I think what we need to try to do is to say that therapy is appropriate for people who need it. Now, the Jimmo case is only about Medicare. It's not about Medicaid, but many people are dually eligible for Medicare and Medicaid. So if Medicaid is paying for the stay in the nursing facility, depending upon how the state Medicaid reimbursement works, some states include a certain amount of therapy in the daily rate, in which case you have to be fighting with the state Medicaid agency to be getting therapy. But some states will have pay an additional amount of money if a resident needs therapy, and that could be done by Medicare Part B. But I think regardless of who's paying and how the stay is paid for, I think the key factor is trying to persuade the therapists and the physicians in the nursing home that this is medically appropriate for individual residents. And it's hard to do. There might be some handles under your state's Medicaid law, but we need to expand the amount of therapy people are getting, because people on Medicaid shouldn't just be abandoned and told time for them to decline. So I don't think I have a great answer about Medicaid law, unless maybe Medicare would be paying for those benefits. But if the facility could be persuaded that it's necessary and put it in the plan of care, that's what it has to get into the care plan. Once it's in the care plan, it has to be provided. So whatever people can do to persuade the facility that this is medically necessary and appropriate for the resident, I would try. Sometimes people have brought in independent therapists to do evaluations. Maybe that would work. Maybe the community physician, the primary care physician, could persuade the nursing home. But I think whatever creativity you have needs to be brought to bear on this, because it's a very difficult issue and problem.
Great. Thank you, Toby. So given our time, we're not going to spend any more time on questions. We had lots of great questions in, and we'll try to follow up with each of you if you email us But with that, I'll give it to Robyn to close it out.
Thank you so much, Alicia. Just a couple of quick points before we close. First, I want to issue a literal call to action. Tomorrow is National Medicaid Call-In Day. The SEIU has made a toll-free number available for anyone and everyone to use. So it's free and it's really easy, and I guarantee you it's easy because I tested it myself today. So it's really 1, 2, 3 easy. 1, just dial the number on your screen. 2, just follow the directions and you'll be told to enter your zip code and hit the pound symbol. And number 3, the phone will be picked up by the receptionist in your congressperson's office, and all you have to do is leave a very short message with that person. We sent out an action alert today about this call-in day. We gave you talking points you can use. So please take those points. Sometimes it's helpful to just write out a few sentences that you can just read when they pick up the phone. But the point is, please make that call tomorrow. It's incredibly important that we flood members of the House tomorrow with calls. They really need to hear from the public because very drastic Medicaid cuts are being proposed that would have disastrous consequences for nursing home residents and certainly for other long-term care consumers as well. So please, it's not hard, it's not time-consuming, and it can make a real difference. So in closing, I want to thank our 3 speakers for the incredibly useful, practical information that they gave us and the tips as well to help us all better understand and apply the revised regulations. We'll post the webinar recording and the PowerPoint slides on our nursing home regulations webpage. We will send you a link to that web page in a follow-up email, so just be looking for that email. There are 3 issue briefs on the 3 topics you heard today that will be coming your way. We've issued one on admission already. We'll be getting the other ones out, the one on visitation and specialized rehab services shortly. So more resources are coming and more webinars as well. So in the meantime, here's our contact information if you have questions or if you need help in any way. So many thanks to all of you for taking the time to join us today, and please make your call tomorrow. So with that, have a good rest of the day, and thank you so much.